Nature's design is there for a reason. You have to believe that. It works really well in pretty much every other species. Nature, it can be cruel, it can be formidable, but to quote Interstellar, but it's not evil. It's design, it has a purpose, and to mess with that system as we are doing constantly, we need to wake up our practitioners to say, listen, the system that you're in really isn't working well, and that's being kind. Can you start to make changes from inside? And we as consumers need to make changes from the outside.
Welcome to the Rewire for Birth podcast. I'm your host, Dr. Cindy. I'm a naturopathic doctor and birth guardian, and I couldn't be more thrilled to have you here. This podcast is all about rewiring the way we think about pregnancy, birth, and postpartum by offering a holistic perspective that empowers you to embrace your journey with confidence and strength. Each week, I'll bring you expert insights, valuable advice, and inspiring stories to help you feel prepared and empowered. We'll dive deep into the transformative experience of bringing new life into the world and explore ways to make your birthing journey truly beautiful.
Please remember that although Cindy is a naturopathic doctor, she is not your naturopathic doctor. This information is made available to you for educational and informational purposes only and should never be used as a substitute for medical advice. Please see rewireforbirth.com/disclaimer for details.
On this episode of the podcast, we have Dr. Stuart James Fischbein. If you haven't heard of him, he is a community-based obstetrician and an associate of the American College of Obstetrics and Gynecology. He's also a published author of the book Fearless Pregnancy: Wisdom and Reassurance from a Doctor, a Midwife, and a Mom, as well as several peer-reviewed papers, including Home Birth with an Obstetrician, Breech Birth at Home, as well as twin home births, outcomes of 100 sets of twins in the care of a single practitioner. After completing his residency at Cedars-Sinai Medical Center in Los Angeles, California, Dr. Stu, as he is known, spent 24 years assisting women with hospital birthing and for the next 12 plus years was a home birth obstetrician who worked directly with midwives assisting local Southern California families. Since retiring from attending home births in late 2022, Dr. Stu has turned his focus to traveling around the world as a lecturer and advocate for reteaching breech and twin birth skills. I cannot believe that these skills are not even taught to many practitioners, as well as teaching respect for the normalcy of birth and honoring informed consent. He hosts the weekly Birthing Instincts podcast with co-host Bliss Young, and together they offer hope, reassurance, and safe, honest, evidence-supported choices for those women who understand pregnancy is a normal bodily function, not to be feared. Please go ahead and follow him on Instagram at Birthing Instincts. And you can also reach him at his website, www.birthinginstincts.com, as well as birthinginstinctspodcast.com. I'm going to list that all up in the show notes. And without further ado, I'm so excited for this episode. We've had to break it into more than one episode because we just could not stop chatting about these important topics. Let's dive in. Welcome, Dr. Stu, to the podcast. I so appreciate you doing this. I know you're visiting family all the way in California right now, and you've happened to snuck into a closet, so we have some good sound. So this is lovely. Thank you.
You're welcome. Thanks for having me, Cindy, and giving me the opportunity to speak to an audience that might not normally hear people like me talk. So thank you.
Yes, I so appreciate it. You have a very unique perspective, and we're going to get into why. But just briefly, you describe yourself as a bit of a unicorn in the world of obstetrics. And I do not disagree with you there. And I want to know how you kind of changed your mindset about so many things, and what were some of the factors that led to those shifts in how you approach the field that you're in, what you might have seen that kind of led to the shifts that happened. I think that would be really valuable for people to hear.
Okay, I am a bit of a unicorn in that I am the rare physician who spent a long time working in the hospital medicalized birth model and then left it for more than a decade of assisting women with birthing at home in collaboration with midwives. So that's where the unicorn title comes from, because it's either one or the other, and most physicians have never even seen or even thought about going to a home birth. But let's go back in time,
Let's do
because
it.
I was a very curious but annoying child, I believe. I was a little bit hyperactive. They didn't call it that in those days. They didn't give you a pill or something. They sent you outside to play from dawn until dusk. But I was always a curious kid, and I had a mom who was a school teacher and very, very thoughtful about things. But she would sometimes say stuff, and I would be the kid that would go, "Well, why?" And then she would say something and said, "But why?" And at some point, she would say something like, she got exasperated and she would say, "Because I said so." And "because I said so" never sat with me. It sort of shaped how I became who I am today, because I was challenging the way things were, but not originally. So I went to medical school at the University of Minnesota, and in the third year of medical school, you begin to apply, third and fourth year, you begin to apply for residency programs when you finish medical school. I matched in Southern California at Cedars-Sinai Medical Center, which was a very prestigious residency and a prestigious hospital to work at. And in those early days, we had an affiliation with LA County USC Women's Hospital, which is the University of Southern California's affiliation with LA County. It was the busiest hospital in the country in the early 1980s. We were doing about 22,000 births a year. And for people who have a hospital locally that's maybe doing 3,000 or 4,000, you can imagine that's 65 babies a day, every day, pretty much, except when Fernando Valenzuela was pitching, and then it was very quiet in labor and delivery. So it's a very phenomenon that those of us who are my age who might remember that, but I'll skip that for now. I got to learn a lot of different things because I saw so much normal and I saw so much pathology. But we were indoctrinated into a very medicalized birth model. But breech and twin birth became just normal for us. As a matter of fact, we were excited to do them. It made us feel like obstetricians, because in those days, every woman was on her back and every breech or twins was hands-on. And for those of us who go into that for that reason, it was exciting. So it was not considered something we were fearful of. As a matter of fact, we would argue over who gets the next one that comes in. So that was the way it was. So when I came out in practice, it wasn't something that was unusual to me, but I began to understand that the hospital system was not conducive to letting women deliver as they were. And my first enlightenment came not from my training, but from volunteering to accept the home birth transports from some of the local midwives. And I didn't do it initially because I thought it was a good idea. I did it initially because I wanted to make money. In the early 1980s, when I came out of practice, you didn't come out as you do now, where you get a job working for a Kaiser or a shift or a mentality place, and you get a salary and that's it. So that's not the way it was then. Then you had to hustle and build a practice. So I covered emergency rooms. I covered other doctors when they were on vacation, or I assisted them in surgery. And I worked free clinics and that sort of thing. And some midwives approached me and asked me if I would take their home birth transports. And I said yes. And that's the beginning of a change in the way I thought about things, because I had never been exposed to any of the things the midwives were telling me. And they were challenging me about things too, like, why am I delivering this woman on her back with her legs up? Why am I washing off her bottom with iodine? Why am I immediately clamping the cord and walking the baby and setting it down in the corner on the warmer? And I started to have to think about those things. And because of that little kid in me that was always questioning, it made sense to me that a lot of the things that the midwives were telling me were much more natural and normal. And many of the things we did in the hospital were stupid. And they were done simply because of habit, because they'd been done that way for so long that no one even bothered to think that maybe they're doing something wrong. And so I began to try to do things differently. I started a collaborative midwifery practice at another hospital up in Ventura County. Cedars-Sinai at that time did not allow midwives to have privileges, so I couldn't do a practice there, but it was an in-hospital collaborative practice, which I ran for more than 15 years. And we had really good results. We had a 7% C-section rate when everybody around us was in the mid-20s. And this was in the 90s. The midwives took care of all the normal stuff, the pap smears, the annual the well woman exams, the prenatal visits, that sort of thing. And if there was a problem, like somebody needed a colposcopy or somebody had an ectopic pregnancy or somebody needed a C-section or a vacuum or forceps or breech delivery, then I would step in. And that was a really great model because our prenatal visits, even in an office setting, were an hour long. And I never heard of such a thing. In the medicalized birth world, doctors essentially to make a living have to work on volume. And you can't possibly give the same sort of care when you're doing volume as when you're doing individualized personal care. And then because reimbursement is so poor from insurance, it's very complicated. Cindy, we could get into a real web of why we're in such a mess and that why no one wants to change it is because it's working really well for those that are profiting from it right now. And that's the truism in pretty much everything aspect of our lives. Why is food still have all this junk in it? Because somebody's making a lot of money doing it. Why is Big Pharma doing all the things that because there's a lot of money in it. We've added all these testing and all these interventions to pregnancy, and our outcomes have not gotten better. We'll talk about that, I'm sure, as we go along.
Yeah, absolutely. I have always been curious to speak to someone who does understand the insurance and the differences in incentives when it comes to different types of interventions. And I'm not sure how much you understand about all of that, but I am so curious when there's an incentive, even as a practitioner, if I have the best interest of my patient at heart, if there's an incentive, even subconsciously, I may lean in a certain direction because there's an incentive for me, right? I think it's hard to grasp that, like, in the birth experience, that someone's behavior or medical decision making would be influenced by money. We just don't want to believe it.
Yeah, I think that you and I are, like many of our colleagues, really good people inside, and we want to do the right thing. The problem is the system is so imbalanced toward doing the wrong thing, to making good people do bad things, because in order to survive and make enough money to justify your office and your overhead and your living expenses, maybe put something away for retirement, when someone's limiting you, when you think you're worth $100 for this procedure and you're getting 12, you have to upcode. You have to do more testing. You have to start to sell hormones or vitamins out of your office. You start to do things because that's outside the insurance realm. So, the whole insurance, it's a big trap for doctors, because once you become a provider for an insurance company and you have 30% of your practices with, say, Blue Cross of California, and they decide they're going to pay you now 20% less than they paid you last year for everything that you do, what are you going to do? Say no and lose 30% of your practice? Because patients tend not to be that loyal anymore. Used to be, when I was young, before I was born, that the patients belonged to the doctor, and the doctor decided which hospital he was going to bring his patients to. But hospitals found that to be very inconvenient because they couldn't control their business model. So what did they do? They started buying up practices, and they started buying up what they call patient lives. And they owned the patients now, and they hired the doctors, and now they have control of everything. And insurance companies and hospitals, they have a sort of a parasitic and a symbiotic relationship all at the same time, because hospitals will negotiate with insurance companies as to what they're going to get for this code, that code, and every code. And so they end up doing things, because if they only billed for this, they wouldn't be able to make a living. But if they charge extra money for this thing, and they do labs they don't need, and they order an ultrasound that they really didn't need, and they send your baby to the NICU for a few hours, which your baby didn't really need. Yeah, so good people get transformed a little bit. And sometimes for doctors, it becomes this Sophie's choice of keep my ethics and lose my job, or keep my job and compromise my ethics. And what do people do when cornered like that? And they put in all that time, and maybe they've got student debt, and maybe they've got a spouse and kids, and they've got expenses, and they can't afford to lose their job. So they go along. Look at all the COVID example of what went on. Didn't convince anybody that the whole system is corrupt. Then there's no hope for mankind. There really isn't. And now doctors, because they've lost so much trust, people might make them uncomfortable. There's a cognitive dissonance when you realize that a system that you believed in and that you hoped had your best interest at heart, and you hear what I'm saying, what you're saying, what so many people are saying, is that it's rigged against you, and they're really not in it for your best interest. The hospital will put out advertising that's saying we want you to thrive and we want you to do great, and we have a mission statement that says that you're number one. But if you look at the actions and you look at the actual fiduciary duty of the people that run the hospital, it's to keep the hospital financially viable. And do they do that by billing less? No, they do it by billing more.
Mm-hmm.
So you're right. Human nature and our wish for goodness would tell us that this isn't going to happen, but it happens, and it's not just in medicine. I mean, look at politics, look at legal system, look at business.
Yeah.
That's the way it works.
Yeah.
So we're not above that. And even though we take an oath, people violate their ethics and their oath every day, and hospitals certainly do. They tell you choices that they want you to follow, as opposed to giving you all the information so that you can make an informed decision. And skewing your counseling is a form of coercion. And whether it's subtle or overt, like, oh, if you don't do this, we're calling Child Protective Services, that is considered unethical by every organization, even organizations I have no regard for, like the American College of OBGYN and the American Medical Association, for many reasons. Their ethical guidelines say that you can never do this, and yet doctors do. So the consumer has to be very distinguishing. You may have heard this before, but we compare the two most important events in a woman's life are generally her wedding day and the birth of her children. That's traditional. Obviously, there's other things. You win a gold medal, there's lots of different things that can do that. But those are the two that you're going to probably remember most during your life. For your wedding, you plan everything. You pick out the invitations, you pick the guest list, you take the dresses, you taste the cake, you pick out the color of the napkins, you do all that stuff. And for your birth, you don't do anything. You've got an insurance card, you've been going to the same person that's been doing your pap smear for 10 years, so I'll just have that person be my OB. You don't look into it, you don't know anything about the hospital, you've really never been taught about the human bodies in high school or whatever, so you really don't know much about the physiology, you don't know anything. You get your information from media and social media and TV shows and movies, and that's what you think. And everybody's yelling and screaming and panicking because someone's baby's coming and you have to rush to the hospital with a baby coming. And this is the culture that we have in America, which shapes the minds of all future moms where we're at.
We're in Toronto, so in Canada, we have covered healthcare, but it's just that we don't pay for it out of pocket, right? But there's still the insurance companies that are paying for everything that happens. And so,
even in a socialized system, the more a hospital does, the more a doctor does, the more they bill, the more the government is the payer, or whatever. I mean, I don't know how it works with you
our
guys,
taxes, essentially, yeah.
Yeah, and so the government is still paying for when you upcode or when you do unnecessary testing, you're still getting paid for that. It's very hard to tell a doctor who orders a test to say, oh, that was unnecessary, because that doctor is the one that's supposedly taking responsibility for that person. So nobody really says anything, and the system just propagates and propagates and propagates. Every now and then you'll hear of somebody who's prosecuted, at least in my country, for like Medicare fraud or Medicaid fraud. But for the most part, you could audit pretty much any doctor's office and you would find fraud.
Wow.
And that's because the insurance companies force us into that situation.
Yeah. It's a system. Like, no matter who is going into that system, the system is what it is. You can have the best intentions, but you're still in this system. For example, a general practitioner, your GP, they only have 15 minutes with you max. And in that time,
if that,
and in that time, they have to assess you, come up with a diagnosis, think of what lab work might help, and give you a prescription. Right.
And not miss anything, and fear that if they miss anything, they're going to be in potential liability situation. So they overorder tests. I used to joke, not really joke, but in a sort of a sad way, that if I saw a pregnant woman with a headache, I would ask her a few questions. I would probably maybe tell her to go home, put a cold pack on her forehead, and maybe drink some water, take some magnesium, do some simple things to try to treat the headache. If she showed up at the emergency room with a headache, she'd have a CAT scan.
Mm-hmm.
Same headache.
Yeah, true.
Right.
Yeah, absolutely. If you don't follow these protocols that are recommended by the health association that you're a part of, you could get your license taken away.
That's correct. You also could lose your job if you don't follow the protocols of your hospital. I know that Kaiser in Southern California doesn't allow women to go past 41 weeks. They don't want women to go past 41 weeks. But any obstetrician knows it's perfectly reasonable to go past 41 weeks.
Mm-hmm.
So physicians in Kaiser have to skew their counseling to tell women something they know isn't true.
Yeah.
I don't know how they do that, actually, but I had a friend of mine that worked for Kaiser, and we talked about it many, many times. And I said, you can go past 41 weeks. He said, yeah, I know, but I have to tell them that if they get to 41 weeks, we have to set up their induction date. That's a policy made by people in risk management, and they should not be deciding. First of all, they shouldn't be practicing medicine, but they shouldn't be deciding one size fits all for it, because that decision belongs to the individual woman.
Mm-hmm. Absolutely.
It doesn't belong to the system, but the system will do it. Same thing with a breech. They'll tell them that if you're 39 weeks and you have a breech, you have to have a C-section. That's all they'll tell them.
Mm-hmm.
That's unethical. It goes on all the time. So what can clients do? What can women do? One is you can learn, if you have daughters, we want to teach them this stuff when they're 14, 15, about their periods, about their bodies. You want to teach your sons the same thing. We don't want to exclude the men. You want to do that early on. You want to set up a health savings account. Almost every state, I think, has tax deductions for it. Put money away so that you're not bound by what your insurance company tells you. If your insurance company tells you you have to go to this doctor at this hospital, and you want to go to that doctor over at that hospital, and you've got money saved that you've been saving since you were 18 years old or 20 years old, you're going to have a lot of money in there.
Mm-hmm.
You put $20 a week in there for 5 years or 10 years, you're going to have a lot of money in there. And use that for your health decisions like you do for your wedding, that sort of thing. And then investigate your community. If you live in a community and you talk to the other women in the community who've had babies, talk to the labor and delivery nurse, go to the hospital, find out, ask questions. If you have an OB, ask the question, if I break my bag of waters at 39 weeks and I'm not in labor, what do you do? What do you do if I get past 41 weeks? Who's on call when I'm in labor? Ask these questions so that you are much more prepared, because you can't change the system. You can control how the system affects you. And then, of course, hiring a strong patient advocate or a doula or something like that who knows your community, who knows the hospital, whether you're having a home birth or a hospital birth. And I would always tell women, even if they think that they should have their first baby in the hospital because they feel safer there, to at least have 1 or 2 prenatal visits with a midwife, not just to compare the difference, but because they might help you have a better hospital-based birth.
Mm-hmm.
Because of the model of care by which they practice. And again, I didn't give credit enough at the very beginning, but the reason I am the way I am now is because of my exposure to midwives and the history that they've left behind. And so I sort of walk in awe and on coattails of the people that came before me. And some of them were physicians too, like Marcin Wagner, Michelle O'Don, but most of them were midwives locally to Southern California that taught me so much, and that I was able to then use the skills that I learned as an obstetrician more wisely and only use them when necessary, until we eventually left the hospital setting, and then I could do pretty much anything I wanted.
How beautiful.
Yeah.
Yeah. So you mentioned that your C-section rate was about 7% in the 90s, when all other hospitals surrounding you were around
High
the
20s, the high 20s. Now we're at about 33%, but
Yeah.
in the 90s, it was in the high 20s.
Yeah.
Remember, in 1970, it was 5%.
Wow.
So we've gone up 600% in the C-section rate, with no decrease in neonatal morbidity or mortality, and slight increase in probably maternal mortality.
Mm-hmm.
Right.
So from your experience, what you've seen, what you've been exposed to, Is there anything that you've pinpointed as factors to why this percentage is increasing?
Oh, yeah, it's very clear to me that the percentage is increasing because of the increasing interventions that the technical medical model of obstetrics keep coming up with, which when I teach, I do a whole little talk on what's called stage one thinking. Stage one thinking is thinking something is going to do good or feel good. So you do it without ever asking the follow-up question is, well, if I do this, then what happens? What's the downstream consequences? What's the stage two consequence of stage one thinking? And the example that I use most often for pregnancy is the continuous fetal monitoring, the belts that people wear. Those belts were put into place in the early 70s, give or take, with the idea that they were going to prevent cerebral palsy. They were going to catch interpartum asphyxia, and they were going to prevent still interpartum death and that sort of thing. And they brought it in. It became universally used overnight. Hospitals everywhere. It was a windfall for the companies that made these electronic machines, made the supplies, made the software. They got legislators to make it something that was required. Doctors' offices began getting them because they could bill for doing NSTs in their office without any proof that it actually did what they said it was going to do. But what happened was now you're monitoring things and you're seeing funny little heartbeats and funny things that don't fit with the standard teaching of what a beautifully reactive tracing, or what now they call a category 1 tracing, is. And so you're seeing these things and you're saying, what does that mean? What does that mean? And everybody's starting to worry now. And then you're starting to over-test. And then you feel like, geez, we're watching this and we're not comfortable with it. Or maybe the fluid's dropping a little bit. It's not oligohydramnios yet, but we're going to suggest that we induce your labor. And so then they induce their labor, and then they don't like the tracing, and then they take them for C-sections. And the number one diagnosis for C-sections right now is this nebulous thing called fetal intolerance to labor, which I would say is more fetal intolerance to induced labor and to all the meddling that goes on. Mm-hmm. And then you add in something called the Friedman curve. The Friedman curve is a curve that was designed by a man named Emanuel Friedman. And it was essentially what I call a great example of stage one thinking, because he plotted how fast women dilated in labor. Now, in order to do that, he had to do vaginal exams every hour or two. So that was the thing that's going to already affect the labor curves. This was, I think, in the 50s or 60s that he was doing this. And so they plotted all these things on a graph. You have all these little dots, and then you get a median from that, and you draw a curve. And then they decided that everything below that curve was moving too slowly. So you want to rupture their membranes or start Pitocin. But if you understand how that curve was first formed, 50% of women were below the curve. So suddenly they're telling 50% of women they're dilating too slowly. Why are we even timing how fast they're dilating? Why do we care? Well, we care because the system needs you to move in and move out. They can't have you laboring for hours and hours and taking up a bed. You shouldn't have been there in the first place. You should have been laboring at home anyway, but that's a whole other story. Mm-hmm. So Friedman curve, one. Continuous fetal monitoring, those two started the process. And then the de-skilling of breech in twins, that's another 5% of all pregnancies. And, 75 to 95% of those breeches in twins are getting C-section, when maybe 5 to 10% need it.
Okay. That's a big difference.
Oh, if I told you the story about unnecessary cesareans, I'll get to that in a second.
Okay, yeah.
And then there's one other thing now that I think has increased it, and that is the increasing reliance on maternal fetal medicine doctors. I think that maternal fetal medicine doctors see everything through the prism that pregnancy itself is a high-risk condition. And therefore, they're always looking for things that are wrong. And by the way, the more they bring you back to look for things that are wrong, the more money they make as well. So there's a real conflict of interests in the model. Because if a MFM sees you at 20 weeks, does an ultrasound, your baby's perfect, says don't come back, he makes less money than if he says, well, your baby's perfect, but one of the kidneys is slightly dilated, so I want to see you back in 6 weeks. So now for 6 weeks, you're worried about the baby's kidney when it doesn't really mean anything, and that person gets another chance to bill you. And not only do all these ultrasounds lead to more interventions, we know that, but then they've added in now color flow Doppler. Color flow Doppler used to have a very narrow indication for severe growth restriction and looking at blood flow. to try to predict if that baby was in dire straits or not. And then it had mission creep. And now I don't think there's an MFM who does an ultrasound where they don't turn it on, because there's an upcode for that. You can bill for that. $100, $135 extra for turning on the code if you have a matching diagnosis code that goes with it. So they make something up that makes it seem like the woman needed the ultrasound. Rule out IUGR, rule out placenta previa, rule out these sorts of things. And they end up finding things that don't necessarily mean anything, but scare people enough to bring them in for either an induction or a scheduled C-section. The whole thing about your baby's too big, your hips are too small. They're trying to get away from using estimated fetal weight as a reason for scheduling a C-section, but there are plenty of places that still do that. There are plenty of places that bring people in for 39 weeks and induce them all because of some flawed trial called the ARRIVE trial. So all these interventions are the reason that the C-section rate has gone up to 33%. And what's crazy, Dr. Cindy, is in some countries, the C-section rate is 70, 80%, with no concern that meddling with nature's design of how a baby is supposed to come into this world is going to have downstream consequences. And anybody will tell you, anybody with common sense will tell you, every time you mess with Mother Nature, there's going to be something that's going to happen downstream. Could be major and it could happen right away. Could be minor, we might not see it for generations. But there's going to be an alteration because nature didn't design the conception, growing a baby, labor, delivery, postpartum system to be flawed. They designed it to be perfect. And it is. And occasionally goes awry. And that's where we need the hospitals and the doctors and the high-risk specialists. But they've turned every pregnancy into something that is labeled a problem. On every doctor's forms, whether it be paper or computerized now pretty much, the first thing that you see is something called the problem list. And the first problem on the problem list of a pregnant woman is what? That she's pregnant.
Yeah.
Right.
It's an
That's
issue.
Right. But it's not a problem. It's a normal function of your body. A woman's body is designed to do this from the time she has menarche until menopause, essentially. Body wants to get pregnant. That's the way the system is set up. So when we mess with that, we did a whole podcast recently about restorative medicine and about the dangers of the birth control pill and how that the menstrual period is your fifth vital sign. And when a woman's having a problem with her period and they say, here, take this pill and cover it up for a decade, you're not fixing the underlying problem.
Nor do you understand your body and its functions and the signals and signs that you're getting from your body. It's very disconnecting.
Yeah, and I think my colleagues in obstetrics are very well informed on anatomy, physiology, biochemistry. They know these things, but they're not putting it all together because they've been indoctrinated in a system that teaches them one way. And when you spend all that time, you come out, and then also now you don't have the ability to make individual decisions. You're just going to go along with what you were taught. Because why would you doubt them? These are your professors. These are the best of the best. But they don't know anything when it comes to natural birth, or they don't teach it, or they ignore it. There was a fake debate between two guys a few years back before the ARRIVE trial came out. So it was like 2018 or 2019. And they were paving the road for this to induce everyone a 39-week bogus, stupid idea.
When you say it was fake, do you mean it was?
Oh, it was a fake debate. When you have a debate, you're supposed to have one person on one side of the argument, one person on the other side. Isn't that right?
Yeah.
Well, it turns out they were both on the same side. They sort of just faked it.
Oh,
and they both came to an agreement that inducing at 39 weeks was a good idea. And one of the guys said something that I'll never forget because the whole audience sort of laughed because they thought it was clever. But me being already who I was, because I was already doing home birth at the time, for sure. And he said, nature is a lousy obstetrician. And everybody laughed. And I immediately thought, what a funny thing to say. For most of us, thank God, nature's a lousy obstetrician. Because obstetricians' outcomes are lousy. They are. We have rising induction rate, rising cesarean section rate, rising NICU admission rate, rising chronic illness rate in our children, And your immune system begins in the womb. We have rising complaints of patient trauma. We have rising rates of postpartum depression. These are not signs of a system that's working well.
Yeah.
And yet, these are the people that are controlling the purse strings and also the legislature in trying to restrict even what midwives can offer or what women in some states, what choices they have. And I just don't think that that's the right way to go. And so I'm hoping that having conversations like this and making women ask the questions. First, when you go to your OB for the very first visit, don't let them do anything. You're there to interview them. I've said this many, many times. Don't let them take your blood pressure. Don't let them draw blood. Don't sign any documents. I mean, if you have to sign something because you can't get into the office, that's fine. But I'm saying, you interview the doctor. Ask him the questions that I told you. That's like, will I see you every time? Will you be at my birth? What do you think about breech birth? Do you have breech skills? Why not? When
Good
they say
question.
no, right? Why not? Ask them, see how they respond. See if they look you in the eye. See if they give you the time of day. See if they have one foot in the door and want to get out and move on to the next task. If they seem rushed and so on. If you have this spidey sense that this is not conducive to you, if you go into the office already a bit nervous and you come out not feeling a whole lot better, then that's a red flag that you shouldn't just give up to your insurance card and say, well, I'm stuck here because I have to be stuck here. Plan ahead for this event because you will remember the birth of your children every day for the rest of your life. You will. And you want to have good memories. I mean, everybody loves their kids, but I've talked to so many women, and again, all you have to do is go on social media posts and stuff like that about women who are traumatized by the birth of their baby. Why should we have that? We're never going to have a perfect outcome. We're always going to have fetal loss and maternal loss. There's a risk, but the system that's in place right now is not doing well.
Yeah. If it was doing amazing and they had beautiful outcomes, then I don't think what's happening right now would be happening, which is this big reclamation process of women being like, wait a second, maybe I can do this better if I have autonomy of my own body, agency, and my baby, and I take the driver's seat and learn about physiologic birth, because I'm curious what you've seen and what you've experienced. Are many OBs even exposed to physiologic birth and vaginal breech birth and vaginal twin birth before they enter their practice?
No, I mean, going all the way back to Business of Being Born, Abby Epstein, Ricky Lake's documentary that sort of stirred the pot. There's a scene where they're interviewing three female residents, and the interviewer asks them, have you ever seen an unmedicated normal birth or something like that? I'm paraphrasing. And they look at each other and they go, no, we haven't. The training of obstetricians, there's a lot less hands-on stuff they're doing now than when I was training because the system has changed and patients' rights have gotten stronger, which is a good thing, actually. But they are not watching a woman labor. They're called to the room by the nurse when something needs to be done, like a vag exam needs to be done or not, but they do it anyway. Or they need orders for Pitocin, or her waters to be released, or they're pushing and they want you to catch the baby, or that sort of thing. But no resident sits in a room for 2 hours doing absolutely nothing but just watching. And then, of course, the women aren't allowed to do the certain things that they would do at home. One of the biggest examples of what I'm talking about is the fact that in the hospital, what's the center of every labor room?
The bed.
The bed. And you're put in a bed as if you're a patient. You're even put in a hospital gown and you're put in a bed. And then the belts are put on you. And that's the focus of where you're supposed to labor and do stuff. And if you've ever been to a home birth, which most of these people have never been, you walk in at any time during labor, you will almost never, ever find a woman laying in bed. She might be on the bed on all fours or squatting or something, but she is not just laying there on the bed on her side, moaning. She's moving, she's drinking, she's eating, she's squatting, she's getting rebozoed. There's a little scarf. There's all techniques for that. And she's in the shower, she's in the tub, she's doing things that help deal with the discomfort and also help the baby rotate and move down into the pelvis. She might feel a sharp little pain in her right hip, and so the next contraction, she lifts her right leg up and puts it on the edge of the bed. If she's stuck in bed with a peanut ball or nothing between her, she can't do those sorts of things. So they make the bed the center of attention.
And
Yeah,
often can't go to the bathroom, right? Can't eat, can't drink.
you got to have permission. There are strict silos, and they need to be broken. We need to do this for the benefit of the women that we're caring for. It shouldn't be turf. It shouldn't be territorial, but it is. And ACOG is an industrial lobby, and they lobby for what they think their members want, but actually, they really do lobby just for ACOG. I mean, ACOG puts out guidelines, two-thirds of which are not based on any real science. They're just based on consensus opinion. And yet these guidelines then become benchmarks for quality that are used by risk management departments and administrative departments of hospitals to put into place. Yet they'll ignore the guidelines they don't want to use. I mean, breech birth in a hospital is supported by ACOG, as is twin birth vaginally. Yet the hospitals will have policies against those sorts of things. ACOG has strict guidelines, as I said earlier, against the use of coercion and other forms of bullying. And yet hospitals will do it all the time. Doctors' offices will skew their counseling all the time. So they'll choose to follow some of the guidelines, they'll ignore the other guidelines, and then they'll say they're setting the standard of care or they're following evidence-based medicine. Both of those terms don't mean what the people think they mean. Standard of care is what a like-minded physician would do in a certain community. So if there's a community that doesn't allow breech delivery, then the standard of care isn't to do breech delivery. But is that appropriate? Is breech delivery not an option that should be available to women? And it should be. So the standard of care is actually substandard.
Yes.
And then the term evidence-based medicine is the same sort of thing. It's like garbage in, garbage out. If the evidence you're using is skewed or biased or incorrect, as much of science is these days, it's been corrupted terribly. It's hard to know when you see a paper come out now whether it's legit or not. It's very difficult to know whether something is good science or not. So you need your trusted sources, people that tend not to have a ulterior motive when they're putting something out. When the paper comes out that tells you to do less, I probably believe it.
Trust it.
Because doing less generates less revenue. So it's harder to have a motive behind that.
Yeah.
Whereas a paper that comes out and says you should now put these new oxygen or lactate acid testing things to screw them into babies' heads in labor now. There's a new thing that just came out.
Yes, I've seen this.
Sure.
Can we talk about this a bit?
Yeah, I only know what I've seen too. I mean, it's basically a fetal scalp electrode that screws into the baby's head and has very narrow and rare indications. But now they've added something where they can check for lactic acid, and that can be an indicator of fetal hypoxia. So it makes it sound like it's a really good idea. But again, this will probably end up being a stage one thing where they think it's a really good idea because someone's going to make a lot of money selling them. But what is the specificity of it? What are the false positive rate of this? What is it going to lead to? Is it going to have the results that we want? Has it been tested? You can't do a randomized double blind. I mean, you could screw something in a baby's head that does nothing,
Right.
but I think there's ethics involved in some of that. So yeah, I don't know, but has it been tested to show that it actually does what it says it does and improve outcomes? Because if it doesn't improve outcomes, what's the point?
And
Ultimately, intentions are useless if they don't improve outcomes.
Right. And the intention is to measure lactic acid, but in doing so, you are disturbing a woman's body in the labor process and screwing something into their baby's head.
Yes.
And so what are the outcomes?
Which I'm sure doesn't feel good for the baby, right? Right.
Yeah.
The baby, it changes everything. Again, you're messing with nature, you're going to have a ripple effect. If they could prove that it was a good ripple effect and that there were no downstream negative ripple effects.
Hey mama, are you ready to transform your birthing experience? We're offering a free guided meditation to help you start rewiring your brain for an empowered birth. Imagine feeling calm and in control, embracing your inner strength, and making your birthing journey smoother and more joyful. Doesn't that sound amazing? It does, right? And it's possible for you. To get started, visit rewireforbirth.com/meditate and grab your free meditation now. Let's make your journey beautiful together.
What do I mean by that? So they don't know how to do breech delivery. So they're telling every woman who's having her first baby who's breech that she needs a C-section. Now, if they do a C-section for 1,000 breeches, they'll save one baby over if they let 1,000 women with a head down baby labor. All right. So 1,000 C-sections to save one baby over head down babies that they allow to labor. Now, what happens if the woman wants a second baby? Okay. Well, that's a downstream consequence because now you have a scarred uterus. And now you have a uterus that's at risk for that thing we call scar dehiscence, or some people call uterine rupture, which can lead to a bad outcome for baby or mother. We also have the risk of placenta accreta increasing every time you have a C-section. Are these things counseled to women when they're told that their baby is breech and the safest route is a C-section? No, they're not. But these are downstream consequences. So screwing a electrode into a baby's head, we don't know what the downstream consequences are.
Mm-hmm. Yeah. And the science, just for people who are listening, because we're talking about all these different factors, what's the quality of the science that's guiding these policies, right? But just that bridge from the evidence to the policies that you're experiencing in a hospital is quite big. And it takes about 10 or 15 years
sure.
before the hospitals start to integrate what the evidence is even saying. So just for people to hear that when they say evidence-based, it's maybe a decade behind of what's actually showing is beneficial for women in the science.
Well, yeah. And Dr. Cindy, when there's a new thing that comes out that benefits the hospital's bottom line, it doesn't take 15 years to be adopted.
Right. Takes a
It
week.
takes like 6 weeks. Okay.
Wow.
So when it's a change that doesn't benefit the hospital either liability wise or economically, it may take a very long time.
Mm-hmm.
And then hospitals, again, I'm not condemning the people that work in the hospitals. I wish they'd speak up more. I wish they would not pretend that they're not harmful or not act as if they don't know what they're doing. But I think that these systems are not designed for the benefit of the patient. We have to face that fact.
Mm-hmm.
We need to find a different way to incentivize the institutions. And there are several problems that can be solved, but we need hospitals. It's not like we want to get rid of them. We need them. But hospitals need volume in order to make money because of the insurance system and because of the overhead of running a hospital and stuff like that. So we can't take the 80% of women who don't need a hospital and take them out of the hospital because then the hospital will close and be unavailable for the 20% that need it. On the other hand, they don't know about physiologic birth. And they had this thing called mother-baby friendly. And before that, they had a thing called let's make the hospital more home-like. Now, to people who've been to a home birth, making the hospital more home-like we know that's impossible. But you could make it more home-like by letting a woman come in, bring her own clothing, bring her own stuff, bring her own lighting, bring candles, bring the people that she wants there, bring her own food, leave her alone, and just be in the hospital because they feel it's closer to an operating room and safer, but leave her alone, don't monitor, don't just leave her there. That would make it more home-like. But no, what did the administrators of the hospital think that makes it more home-like? Hardwood floors and curtains. They made the labor rooms look more like a bedroom. That's the thought process of people in administration. They don't get it. And the same thing with Mother Baby Friendly. Mother Baby Friendly was like the good housekeeping seal of approval that they wanted. And so they went to Mother Baby Friendly. And then the minute COVID hit, Mother Baby Friendly was gone. No, you can't have your husband there. No, you can't have your doula there. Oh, you've got COVID. The baby needs to be isolated. No, you can't do this. You can't do that. Yeah. So they really weren't committed to these things. You can see that by their very nature that this is all marketing. Mm-hmm. It's marketing. It's propaganda. It's what makes the hospital get more business. And I understand that's the business model, but that people have to differentiate that from thinking that that's for your own well-being, because it isn't. You have to fight for your own well-being these days in the hospital setting, and you can hire a patient advocate or a doula. You can seek out the hospital that's better for you, even if you have to drive 30 or 40 miles to a different town to go to a hospital that has a better reputation, better doctors, better midwives, or collaborative practices. Hospitals really have to post their C-section rate. Individual doctors don't, but hospitals are supposed to. Look at their C-section rate. Ask about breech in twins because you have a 5% chance before you conceive of having a breech or twin baby at term. That's 1 in 20. It's not that uncommon. OBs these days can't take care of 1 out of every 20 women that walk into their office. They're not experts in it. Yet they're labeled experts and they can only offer cesarean.
Mm-hmm.
I'd be angry if I was an OB out there who didn't get trained in my residency program when I'm protected in the skill that I need to take care of 1 out of every 20 pregnant women.
Yeah, that's the job.
Right. I mean, it's ludicrous to think that a heart surgeon would say to you, I'm sorry, that's your left descending coronary artery. I'm only a right descending coronary artery expert. Okay. I don't even know if there is one, but I don't remember my cardiac anatomy. That would be crazy. He can only take care of this thing and not that thing.
Mm-hmm.
When you're a cardiac surgeon, you take care of all things hearts. You might have subspecialties and people that just do valves, but nonetheless, you are a cardiologist. You take care of all things heart.
Mm-hmm.
Obstetrician, you should be able to take care of all things obstetrics, and they can't.
Yeah.
Again, the system is totally flawed, and the system propagates itself for the system. And all you, again, have to do is people can argue and they can say, I love my doctor, I love my system. Yes, there are exceptions, but look at the overall outcomes. Statistics don't apply to the individual. I mean, you have 100% chance of having a great birth or 0% chance. It's not 42% or whatever. But overall, we're looking at numbers that are constantly getting worse in my lifetime.
Yeah. And the trauma factor is huge. With it, it's almost at half. It's about 45%,
That's what I've heard.
which is way too much.
And do you think the other half are in denial? No, I'm just kidding.
Yeah. What does a woman look back and consider trauma? Often it's that she felt like her voice wasn't heard, that she wasn't listened to, that she was coerced into something that didn't feel right. Because a woman can have an emergency C-section and feel very well taken care of. But a big one is the coercion, is feeling like birth was happening to her instead of through her, instead of her being supported and well informed with what's going on around her. And then we're not even taking into consideration the secondhand trauma of their partners and of whoever was supporting that woman.
That's such a good point.
Yeah.
When you go to the hospital, you tend to give up your sovereignty, but the hospital also does sort of make the partner into a third wheel in many situations. And there is good data out there that says when the husband is integral, or the partner, could be anything, but just conventional, when that person, that male especially, because males are sort of awkward around birth, they don't really know how to help their woman. But when they're involved, when they're supporting their partner, when they catch their own baby, the bonding that goes on between the man and the woman and the child, there's evidence that those relationships are stronger and will last longer. And again, the medical system doesn't really take that into account either. I'm fairly well famous for this saying that all that matters in the medical model is a live baby in the bassinet. And what happens to that baby, that mom, and that mom's future babies is not the concern of the current hospital system. That may sound callous, but it is absolutely true, 100% true, because you look at outcomes and actions and you can see that mentality is not what the midwifery model is about. That mentality is brought on because the hospital looks at the whole thing differently. They look at it as a business, and if you get a healthy baby, they're not going to be sued. If the baby isn't healthy, but they did everything that they could do intervention-wise, and the baby goes to the NICU, then they're not going to be sued, and they made more money. They don't care about the baby's microbiome. They're not asking, how did that baby do a year from now, 5 years from now, 10 years from now? They're not asking, how did that woman do in her subsequent pregnancy? Did she have a ruptured uterus? Did she have a placenta accreta and end up with a hysterectomy? Because we did a C-section for Breech without offering her a vaginal delivery. There's no accountability to that degree. Yet when something goes awry at a home birth, it's all hands on deck. Oh my God, oh my God, oh my God. I will tell you that over the last 15 to 20 years, the rate of newborn intensive care unit admissions in the United States has nearly doubled from about 5.5% to like 9.8%, according to the most recent CDC data. There are two reasons for that. Neither one speaks well of the medicalized birth system. One is that our system is creating babies that are sicker for whatever reason. They can blame it on the woman if they want. Oh, she's overweight, or she's doing drugs, or she's too old, or whatever, which is the mechanism for clearing cognitive dissonance. Or the other reason's even more sinister, which is that because NICUs are the money-making engine of the OBGYN world, that they find more reasons to put babies in the NICU. And one of the things that happened in 2020 was that the Society for Maternal Fetal Medicine decided that they were going to redefine growth restriction as babies under 10th percentile. It used to be under 3rd percentile, plus a few variables to that. But in general, they raised it to the 10th percentile. Now, why would they do that? Well, what's more worrisome, a baby that's growing in the 8th percentile the entire pregnancy, or a baby that was 50th percentile that's now 20th percentile?
The latter.
Right. But the 20th percentile one wouldn't fall into the category. Yet they're saying that 10 percentile it does. So what they're saying is that 10% of American babies are growth restricted. And what do they do with the baby they suspect to be growth restricted? They bring them in constantly for more testing. And who's doing the testing? Maternal fetal medicine, members of the Society for Maternal Fetal Medicine. So they're always going to use safety as a canard for the reason why they're doing it. French philosopher Albert Camus said the welfare of humanity is always the alibi of tyrants. And so they're going to tell you it's going to be safer, we're going to pick up more babies. But again, like everything else they do, it's stage one. Are they picking up more babies? Are all the extra testing they're doing and all the color flow Doppler they're doing solving any problems, saving any babies? And if they are, even a small number, at what cost to all the babies that got induced because they had funny testing that really didn't need to be induced? And then they ended up in the NICU. So,
and not taking into account the experience of the mother throughout that, which has profound impacts in the postpartum period as well.
Right, because all that matters to that system is getting a live baby in the bassinet. That's all that matters.
The phrase that keeps coming up to me as you're speaking is "you will know them by their fruits." If we look at nothing, like we just assume everything that in the system is true and for the best interest of the patient, both the mother and the baby and the whole family unit, let's just assume that. But then we look at the outcomes, the fruit of this system, and it's not improving over time. We have higher rates of trauma and postpartum depression, postpartum anxiety. We have higher rates of pelvic floor dysfunction. And you're right, looking at just the health of the baby, the microbiome, allergies, ADHD, all the behavioral stuff for kids. We're not looking at any of that. And it's not improving with this system. So if we're just looking at the outcomes, it's not doing very well.
Yeah, and even worse than that, Cindy, is many of the things that they do have not only do have no evidence of benefit, but they have evidence of non-benefit, and they still do them anyway. The perfect example, again, is continuous fetal monitoring. There has been no decrease in the rate of cerebral palsy or intrapartum stillbirth or hypoxic ischemic encephalopathy, despite universal use of continuous fetal monitoring. As a matter of fact, that even intermittent monitoring hasn't been shown to prevent these sorts of things. But the idea that we're going to continue to do that and then misread the heart rate tracings and end up doing all these C-sections, that is evidence of non-benefit. We're better off not monitoring any woman in labor as we did in the 60s. Because at least in the 60s, women delivered vaginally. Now, a lot of them ended up having twilight sleep and forceps like me. Because that was the thing in the 50s.
Did you? That was your experience? Your mother's experience?
Oh, that's how I was born.
Oh, wow. Yeah.
Right. I was my mom's second baby, and my mom got to complete. And once she was complete, they knocked her out and they pulled you out with forceps. That's what they did in the 50s.
Yeah.
Right.
I just think of the experience of the mother. It must
Oh
be
yeah,
so
complete
surreal.
disconnect, a complete disconnect.
Completely. Yeah.
But the outcomes weren't worse than they are now.
Yeah.
And the C-section rate was 5%, and the induction rate was almost non-existent. And they didn't
Wow.
have a Friedman's curve, and they didn't have
Mm.
continuous fetal monitoring, and they certainly didn't have ultrasound. In the early 70s, 1 out of every 3 women had an ultrasound. Now, about 75% of women have at least 3 ultrasounds,
Mm-hmm. If not
and
more.
their outcomes are worse
Yeah.
or not better. So, what's the point of doing all this stuff if our outcomes aren't getting better?
Mm-hmm.
And
Can
point,
we?
I can tell you, is monetary gain. What else is there?
Yeah.
Control. It's so funny that one of the most misogynistic things that you can think of is obstetrical care.
Yeah.
It's really
Let's
weird.
dive in here because I've been dying to go down this rabbit hole with someone. So, in what I've seen and speaking to many people, experts in the field, different women who have had different experiences, their partners, doulas, I feel like the overarching theme is this disconnection from one of the most profound, empowering experiences you can have in this lifetime as a human, because it wakes something up in you. It
Yes.
activates something in you, and you begin to see the veil of reality for what it is. And this might be far out for a lot of people who are listening, but it is a control mechanism. You are much more likely to be subservient if you experience trauma when you should be experiencing the most powerful, euphoric thing that's possible for you in this lifetime.
Yeah, fear is what's used to get women to be compliant. The more you want something, the more anxiety there is about it.
Mm,
There's somebody once said the secret to happiness is having no expectation. All right. Because nobody wants their baby to be damaged in any sort of way. Everybody wants a perfect baby. And so they'll do anything they can. And when their doctor says, I think your baby might be in trouble, or your baby's not growing well, or your placenta is looking a little old, or you're looking a little old, or whatever, those are triggers. And so it generates this fear that then also detracts from this beautiful thing that you're talking about. Again, I'm not a woman, I haven't experienced it. I've been as close as you can possibly get, both in my own personal life and also obviously professionally. But I can't speak for it as my female colleagues can, or the women that I've cared for. But to be able to grow a baby and to deliver a baby is sacred, and it's sovereign. And the system has basically destroyed that. And we are trying to get it back. And you have the best chance to get it back right now in 2025 by staying out of the hospital. Because even though you may feel safer in the hospital, you are realize that you are giving up some sovereignty and the sacredness of the space to people who don't feel the same way as you do. And you have no control over who's in your environment. You may love your doctor, but maybe your doctor's in a group of 6 people, so your doctor's only on call every 6th day. And you may love the nurse that you're assigned when you get there, and then 7 o'clock rolls around and it's change of shift, and now you get somebody else. The system isn't designed that way. When you have a birth center or a home birth, you are generally with the team that you've been with the entire time. As most people know, if you have a midwife, she may be at your house for 40 hours. We've all been there. We've all had births like that. But it's the same person, or
mhm.
the same 2 people on maybe a 2-person midwifery team or whatever. And then you have people at your house that you enjoy and that are supportive, and you can exclude people who are naysayers or give you negative energy or make you nervous. Maybe your mother-in-law, you don't want her there because she's afraid of you having a home birth or whatever. But you get so much more control over it. And then this monumental moment of birth and reaching down and grabbing your own baby and leaving the cord alone and pulling the baby up onto your chest and sitting back if you were squatting or lying down or whatever you're doing, and just laying there with your baby and your partner oohing and eyeing at your baby while your midwife, who acts like a ninja lifeguard, is basically scooting around and just listening to the sounds you're making, the sounds baby's making, and looking at the baby and making sure everything's fine, and then just leaving you alone. There's none of this, we have to get this done. We have to cut the cord. We have to get the baby washed off. We have to get the baby wrapped up like a burrito. We have to give the baby its eye ointment and its vitamin K and, God forbid, its hepatitis vaccine. Why do you have to do those things? We don't do those things at home. Women have babies at home all the time without an IV, without having blood drawn, without being monitored, without being starved or told they can have a popsicle or some ice chips. No, they can have whatever they want because they need the energy. It's a different environment. And what's troubling, however, Cindy, is even midwifery now, if you're going through the medicalized midwifery schools, you're going to find that midwives are now sort of becoming mini obstetricians. And that's why we're doing our best to push on traditional midwifery and making sure that that survives. And my partner Bliss is working on a project right now called the Breech Midwives Project, where she's going around the United States and interviewing some of the granny midwives to make sure that their wisdom is documented, because otherwise we're going to lose it. And it's very important that people that are interested in that sort of thing should try to keep that alive.
Yeah. Just thinking of the lineage of wisdom that could be dying off if this work isn't done, if it's not documented.
Yeah, if Breech Without Borders wasn't around and I wasn't around, there would be nobody pushing breech delivery in the United States. And it's essentially died since 2000 in medical schools and training programs. They're not teaching it anymore. And no one's coming out confident enough to do, because they don't see enough breaches done vaginally because there's nobody doing them. And the people that are the instructors in residency programs are generally maternal fetal medicine doctors, and they don't know how to do them anymore. So they're not teaching them, and everyone's going right to the scalpel. And this is not conducive to a system that's going to improve. And so then what we need the midwives to continue the lineage, and also they're the torchbearers of this skill until medical schools and residencies turn around again, get some common sense back, and realize that what they're doing not only isn't working, but isn't even desirable by more and more women. I mean, if it is a business, then their business model is sucking.
Yeah. Yeah. And that was a big statement that you made, that for a mother to have the experience that she desires, her best chance in 2025 is to stay out of the hospital.
Yeah.
That's a very big statement. And I think it's very valuable, especially coming from you, just based on your experience and your knowledge and your expertise and what you've seen and the knowledge that you receive from Bliss as well. So I just want that to sink in for the listeners, because that's a bold statement, but it is what you're seeing.
Yeah, I would say that it's true. I would say that there's documentation that it's true. There's a huge study out of Europe, over 500,000 women, comparing equal cohorts of what they considered, quote, low risk women. And in every category, the outcomes were better at home. Are they perfect? No. Is somebody going to lose a baby? Of course. It happens in the hospital all the time as well. People don't hear about it or understand that when something bad happens in the hospital, everybody thinks that they did everything they could. But the truth is, in many cases, whatever happened to that baby was iatrogenic, and it was caused because of what they were doing. And then they try to fix their own problem. And then they pat themselves on the back for getting a baby out through a crash C-section that was perfectly fine yesterday when it was inside its mom's belly, coming in for an unnecessary induction. Why do I say that? Because the induction rate, again, has tripled since 1990. Have we really gotten that much worse? And by the way, the tripling of the induction rate, has it improved outcomes? And the answer is no. Mm-hmm. So what are we doing?
Mm-hmm. It's all based on the ARRIVE trial, correct?
This was happening before the ARRIVE trial. The rate of these things were happening beforehand. The rate of induction increased after the ARRIVE trial, but the rate of induction was already rising. Mm. And so it just accelerated the rise. It didn't cause the rise.
Right.
Yeah. Again, if all that matters is a live baby in the bassinet, why not take that baby out at 39 weeks? Because we know it's alive. Mm-hmm. Giving Pitocin, artificial oxytocin, altering the whole process, bringing a baby out before it signals to its mom it's ready to come out, none of that seems to matter. giving mom an epidural or giving her fentanyl or forcing a baby to come out with Cytotec and a Foley balloon and all these things just because your doctor is uncomfortable or it's for expediency, convenience of doing it. He's going away or he doesn't want to be busy on the weekend or whatever. And so he gives you a reason, he or she skews their counseling to funnel you down the path they want you to take to get you to do that. I had a consult yesterday with somebody here in LA, a couple, and she feels safer in the hospital. And so we had a long talk about how to have the best birth you can have in the hospital. She's already had one vaginal delivery. And so the chance of her having a problem, when you do a home birth and you have a woman who's called a multip, it's a woman who's already had at least one vaginal delivery. Every midwife will tell you that they're thrilled. They love getting that client because they know they're not going to be there that long. They know the labor is going to be faster. They know the risk of transport to the hospital is going to be probably 1%, maybe 2%. Whereas with a first-time mom, it might be 10% or a little bit higher. And that generally for stalled labor, not for emergent things. It's very rare to take someone from a home birth where you're not meddling with Mother Nature and have that rapid deterioration of the baby's status such that you need an emergent ambulance transport. Most transports from home prior to delivery are mom's exhausted, labor petered out, she's stuck at 8 centimeters or whatever else. Maybe she needs an epidural and some relaxation. And so they get in their car and they drive to the hospital, just like they would have if they planned to go there anyway. So that's what most of those look like. But for low-risk women to be at home, you're far more likely to have the birth that you desire. We just have to get over the fear. And again, the fear is the way you manipulate people. It's called mass formation. You can get people to do anything. 15 days to slow the spread, stand 6 feet apart, don't go to church. And we all did it. Right?
Yeah,
Not all of us, not all of us, but most of us just fell right in line because we trusted the source. We have to be wiser than that. We have to understand that your doctor, your midwife may be really good people at the hospital, but they're working in a system that's really crappy, that isn't designed to support the individual woman with her individual choices. They very much work on an algorithm. Every set of dyed twins in that system has to be ultrasounded at this schedule and has to be induced at this week. But that's not the case. Every diabetic is treated the same. And they're treated as if the baby's going to die at any minute. But a well-controlled diabetic is really not at much greater risk than anybody else. And yet they'll want you to be induced at 38 or 39 weeks if you're a type 1 diabetic, even if your blood sugars are better than mine or yours, because you carry that label. It's high risk to label someone high risk because you change the chemistry inside their body throughout the entire pregnancy.
Absolutely.
You start planting seeds of doubt early on. Your hips are small, you're over 35. Your last baby was a really tough forceps delivery. Maybe you want to do a C-section this time. And you're starting to put those seeds into somebody. And why are you doing that? Do they think that that's good medicine? Maybe they do. I don't know. But it isn't.
Happens so early on too. They're told they're going to be induced at 39 weeks in the first trimester. How do they know it'll be better for the baby to come out?
Because they believe that all babies should come out at 39 weeks. Any doctor that says that to you is a doctor you shouldn't be going to. By the way, we don't have to get into this topic, but I will just tell you that ACOG and most OBGYNs are all supportive of giving a woman 6 vaccines while she's pregnant. 5 of them at the same time, 3 shots, 5 vaccines at 28 weeks. Any doctor that says that you should have the COVID vaccine or that you need a flu vaccine or a DTaP vaccine or an RSV vaccine, that you must have it in pregnancy, is not a doctor that I would trust. Because first of all, you just ask the doctor, could you show me the safety testing on these? Because there isn't any. Not only is there none in pregnant women, there's none in anybody, in any of the vaccines. There's no randomized double-blinded controlled trials in any of them. And yet, if your doctor suggests that you get these, that would be a red flag for me. Why would I want to stay with somebody who believes that? Now, they may say the opposite. They may say that Dr. Fischbein guy, he's crazy. And he's an anti-vaxxer. Yeah, I am, actually. I have become what they would call an anti-vaxxer because I don't believe that injecting stuff into your body that's never been tested for safety is a good idea. And injecting it into a 1-hour-old baby or a pregnant woman in violation of a principle that has stood for a long time called the precautionary principle, which is that we don't test substances on women who are pregnant or lactating. We just don't do that. But that disappeared in 2021 with the COVID vaccine. Suddenly, you were giving it to pregnant women without any testing whatsoever.
Mm-hmm.
And now the research has been more than clear that not only is there no evidence of benefit, but there is strong evidence of non-benefit. And yet the American College of OB/GYN is still recommending it for pregnant women. It's insane. They recommend a DTaP shot, which is diphtheria, tetanus, and pertussis. They recommend that in your pregnancy. It's got 250 to 400 micrograms of aluminum in it. Again, never been tested for safety. I mean, there's a paper that came out this week that said aluminum isn't a neurotoxin. There are already controversies flying about this paper. That's why I don't trust science anymore.
Yeah.
But if I got a DTaP shot, which I won't, but if I did, when would I need another one? And they would probably tell you a tetanus shot every 10 years. That's what I was taught as a kid. Okay, you can't get a tetanus shot anymore. You have to get a Tdap shot. So you get 3 things instead of 1, which is all you want. But if you're pregnant a year after you've had just first baby, they want you to get another DTaP shot in your next pregnancy too. Well, make sense of that. Okay, I can't.
There's a lot of make it make sense moments in this realm.
Cutting the cord immediately, taking a baby to a warmer, having a woman on her back with her legs in stirrups, being dressed in a full hazmat suit to catch a baby. There's no rhyme or reason. They've made pregnancy into an illness with a surgical technique, a delivery. You don't do it with any other mammal.
Mm-hmm.
Mammals give birth in the straw, in the dirt, in the grass. It's not a sterile procedure. It's not designed to be a sterile procedure. Your immune system is designed by nature to want to be challenged. You want to be colonized by the right bacteria. These things are just not part of the medical training. Or if they are, they become subservient to algorithms and systems and policies of the hospital.
Yeah, there's so many factors that you're bringing up. If we're trying to put the puzzle pieces together, one is the education of the practitioners, the lens that they just view pregnancy through and labor and birth through, which is the lens of risk. What can go wrong here?
Fear. Yeah. They're trained in a fear-based model. Doctors are trained to fear birth as a potential problem at any moment. And therefore, that's how they see it. And so everything stems from that. You can explain everything they're doing, but everything they're doing, again, doesn't have any logic because the outcomes aren't better.
Mm-hmm. Yeah. Yeah. So there's the education, the lens of fear, their approach, the paradigm, the system, the insurance, the policies, the fact that hospitals are essentially a business. And then there's the whole conditioning of all of us, of our culture since childhood, that this is a scary event. And what do? We rush to the hospital. We call an ambulance right away. We scream because it's painful. We're ready for the pain. Things are compared to birth and labor as like that's the benchmark of the most pain that someone can endure, right? And so if that's how we perceive it ourselves, and all the movies and all the shows perpetuate that, we're not being trained as women in what can happen in our bodies, what's possible, how to navigate the waves and the intensity of this experience, and seeing it as what's supposed to happen instead of this thing to fear. Yeah, all these factors just come together to produce
when you birth at home and you have children that are old enough to know what's happening, they will never look at birth the same way with the same sort of fear. They'll remember that mommy gave birth to Susie at home and I was there and I got to cut the cord and I remember all that stuff. Most of us grew up with the idea that moms in labor were shoveled off to Aunt Betty's house. They went, 2 days later, they came home with a package. and our experience of where babies come from. We don't understand it. And we think that going to the hospital is the norm because for 70 years now or 80 years, that's the way it's been sold to us. And therefore, we've sort of sterilized the idea of how we come into the world from several generations. We've also done that with death as well. People used to be born and die in the same house. And little kids were exposed to both the birth of their sibling and the death of grandma. And so it wasn't as scary. And the grandma was able to die in the place that she felt most comfortable with those that loved her around her. And that's been taken away, and that was really taken away during COVID. I mean, people died alone, isolated. It was inhumane, close to evil, what was done by these same people that are now telling you that this is how we should birth our babies. See, they're the same people. The doctors were doing this at the same time. They were so scared, and they would say, well, we're just following orders. And that echoes of Auschwitz, by the way. Mm-hmm. When you hear people say we were just following orders, you had to know it was wrong to deny a woman to be with her doula, her partner, or to be separated from her baby because she tested positive. She's feeling perfectly fine, and she had a Q-tip spun around in her nose for 10 minutes. And then they did 42 cycles on it and finally found that she tested positive for COVID. There were stories where you could swab a tomato and it would test positive for COVID if you cycled it enough times. So again, we were just led astray, and the people that made the PCR tests made a fortune. So many people made so much money during that period of time, and so many people have suffered.
Mm-hmm. And the downstream effects of that are now the hospital systems are more stressed. There are fewer employees, more burnout in those employees.
And fired the good ones.
And that left more of a burden on anyone who was remaining. And then some of the policies and procedures are lingering, right? And so there's a desire for a faster turnover in the labor suites. So it's what happened 5 years ago, 4 years ago, 3 years ago. The effects are still lingering. But I think one of the positive things from that was there is a little bit less trust, more inquiry, more skepticism of the medical system, which I don't think is a bad thing. I think people are just questioning things more, which I quite enjoy.
I think it's a really good thing. I think that organizations like the American College of OBGYN are becoming obsolete. And I think their current president is a zealot. They'll say one thing, but the actions of the ACOG and stuff like that show you where their priorities are. And their outcomes do not belie what they say that they're trying to do.
Thank you so much for joining us on today's episode of Rewire for Birth. We hope you found our discussion inspiring and empowering. If you enjoyed the episode, we would greatly appreciate it if you could leave us a review on your favorite podcast platform. Your reviews help us reach more listeners and spread the message of holistic, empowered birth experiences. Feel free to mention what you loved about today's episode and how it helped you feel more prepared and confident about your birthing journey. Your feedback not only encourages us, but it helps other moms-to-be find our podcast and join this incredible community. Together, we can make a positive change in the world of birth. Until next time, stay empowered and keep rewiring for birth.